Welcome back, everyone. Today I will talk to you about hip joint. So first of all, let me give you a brief introduction about the hip joint, in which it's a synovial joint. We'll talk about that more. And it's located between the head of femur, as you see here, and the acetabulum, which is a socket-like structure located in the lateral side of the hip bone. So it's between head of femur and acetabulum. And if you look at both of articular surfaces, I mean the surface of the head of the femur and the surface of the acetabulum, you will see that they are covered by hyaline cartilage. So let us start with the head of the femur. Yes, this is the femur, and there is a lecture about the anatomy of the bone of the femur and patella. So if you want to dig deep on different structure there anyway. So for the head of femur, guys, you see that it's more than a hemisphere. It's not, it's about 2/3 of the sphere, right? So that helps, of course, the or enhance the stability of the hip joint once the head of the femur articulates with the acetabulum. So it's a globular shape, it's smooth, covered by hyaline, as I mentioned, and it has near its center, not exactly in the center, near its center there's a kind of a cavities here, non-articular part, which is the known as fovea cavities. We mentioned that previously. So this fovea cavities is the location for attachment of intracapsular ligament. Well, we talk about the head of femur. Yes, so this ligament is the ligament of head of femur. We will talk about this ligament as well. So this ligament, anyway, consider as intracapsular ligament. Back again to the head of femur. Yes, it has a fovea cavities near its center, so I will give you just extra information about that. This is the center of the head of femur. So the fovea cavities that I'm talking about it here is located just a little bit below and behind this center. So I would say almost here, right? Yes. So that was the head of femur. What about the acetabulum? Yes, you know that the acetabulum formed by three bones, pubis, ilium, and ischium, and there is a lecture about that. But here I'm talking about the articular surface of the acetabulum. So it has articular surface and central non-articular surface. So this is the non-articular part known as acetabular fossa. Acetabular fossa. Okay, what about this is the articular part, which is like horseshoe shaped, right? C-shaped or horseshoe shaped parallel explanation with a defect inferiorly. But that means it's incomplete. That's why it's called lunate. Lunate surface, articular surface, or lunate surface of acetabulum. So the of course the acetabulum deepened by a fibrocartilage that you are looking for now, which is the acetabular labrum, which is a fibrocartilage rim, right? Anyway, inferiorly, the gap of the lunate surface or the acetabular labrum completed by a ligament, transverse ligament. Because it's in acetabulum, so we call it, which is simple to remember, transverse acetabular ligament. Transverse acetabular ligament. So till now we have two ligaments. We mentioned two ligaments. This one, the ligament of the head of femur, and transverse acetabular ligament. We'll talk about both of them, but you have to remember that both are intracapsular ligaments. That means ligaments inside the capsule, inside the joint, right? So what else we have here? Yes, because of you remember that maybe from the previous lectures about the bones of the of the about there's a lecture on bony pelvis, so we talked about the acetabulum, and there is a notch here which is acetabular notch, because this is acetabulum, right? So there's acetabular notch here, and because of the presence of this transverse acetabular ligament, it converts this notch into a foramen known as, from the name again, acetabular foramen. Acetabular foramen for blood vessels and nerves. So these, I think, the most important structure here. And as I mentioned, this is synovial joint. Exactly, it's a ball and socket joint. It's like a ball in the socket, right? So also, I think you remember, if you remember the humerus, the shoulder joint, sorry, in which the head of your humerus and the glenoid cavity, also they we consider the shoulder joint as a ball and socket. This is an X-ray. I think you can have a look and define different anatomical landmarks can be seen there. So, like for example, this is the head of femur, and this is the acetabulum, this is the neck, greater trochanter, lesser trochanter, and intertrochanteric crest seen from here, ischial tuberosity, obturator foramen, and so forth. Okay, back to the joint. Yes, we have articular surfaces covered by hyaline and so forth, and different structures there. And we know that this kind of joint is covered by capsule, right? So this is the capsule. And the capsule is simply is a dense fibrous connective tissue, right? So the most important here, where's the attachment of the capsule medially and laterally? Medially, very simple, you can see the green color here, so it attached to the margin of acetabulum, because this is the acetabulum, right? So attached to the margin of acetabulum, and also to the inferiorly. If you look here, you remember the transverse acetabular ligament. Yes, so it attached to the transverse acetabular ligament. Okay, that's laterally. That's, sorry, medially, right? But what about laterally? Well, before talk about laterally, let me show you this figure inferiorly. You look into the hip joint anteriorly. Look at the capsule that attached to the margin of acetabulum, and laterally, anteriorly, right? I'm talking about anteriorly. Laterally, it attached to the intertrochanteric line. You remember the line between greater trochanter and lesser trochanter anteriorly? It's known as intertrochanteric line, right? Okay, but posteriorly, the capsule will not reach the intertrochanteric crest. No, it's gonna just be short and will continue up to this level, to the mid, I would say, mid of the neck or so forth, but we can say exactly it's proximal to the intertrochanteric crest. That means in the neck. So, yes, medially, and let us shift to this figure. Laterally, anteriorly to intertrochanteric line, and sometime it gives like a fiber extended over the head and neck. These fibers known as, which is not shown here but shown here, right? Known as retinacula. Retinacula. This retinaculum should be here, and this is another retinaculum. So this retinacula to carry blood vessels to the head and neck for supply, right? So that's anteriorly. But what about posteriorly? Yes, we mentioned that it will not reach the intertrochanteric, but it will be like in the posterior aspect of the neck, as I mentioned. Okay, ligaments. This is very important, and you have to know a little bit of details about the ligaments of the hip joint. You have mainly five ligaments. We mentioned, but we will talk more about that. We mentioned that the ligament of the head of the femur, which is shown here, and the transverse acetabular ligament, this one. Well, it's good to say that, you know what? This ligament, the ligament of head of femur, originates or attached to the transverse acetabular ligament. Just keep it in your mind. So, there is an easy way to remember these three simple ligaments. First of all, you know the hip bone, which is formed from ilium, pubis, and ischium. And you know this is the hip joint. So you have a ligament from each one. So that means you have iliofemoral, because it's attached to the femur. Iliofemoral, which is like Y shape anyway. We'll talk about that. Iliofemoral, and you have pubofemoral, and you have ischiofemoral. Very simple. Let us start with the strongest ligament and the most important one, which is the iliofemoral ligament. This is the iliofemoral ligament, which it looks like inverted Y shape. Look at it here. So I will draw it in this way. So it's inverted Y shape, in which its base attached to the anterior inferior iliac spine, and it has two limbs because it's inverted Y shape. They are attached to the upper and lower intertrochanteric line. You can say intertrochanteric line, that's also fine. Right? It's very simple. Anterior inferior iliac spine and to the intertrochanteric line, because mostly is anteriorly. So this is the strongest ligament in the hip joint. And sometimes they say it's the strongest ligament in your body, but sometimes they say calcaneal tendon is the strongest. Anyway, so what's the significance of this? It limits the overextension of the hip joint. There is another ligament, which is the, as we mentioned, the pubofemoral ligament. This is the pubofemoral ligament, as you see here, which is also a triangular shape, in which the base of it attached to the superior ramus of pubis, because it's a pubofemoral ligament. So the superior is a superior ramus of the pubis. So this is the base, and its apex. Its apex is attached to the lower part again of intertrochanteric line, just deep to the iliofemoral ligament. The function of this ligament, when you imagine the movement of the hip, it limits the abduction, right? Because here, so it prevents the over abduction or limits the abduction and also the extension of the hip joint. The third one, which is the weakest one, in which now you are looking to the posterior aspect of the hip joint from the back, right? So this ligament, which is like a twisted or spiral in shape, the ligament is like spiral in shape, then known as ischiofemoral ligament, the weakest one of the three ligaments, which is important. That means, why it's important? Because when male you flex your leg, you have to expect a posterior dislocation of the hip joint, right? Because of the weakest, the presence of this weak ligament posteriorly. But anyway, this ligament attached medial to the body of the ischium, near the acetabulum, and laterally to the greater trochanter. Imagine the function of this ligament. Suppose you want to move your leg like that, I mean the medial rotation, so it limits the medial rotation of the hip joint. Again, back again to the intercapsular ligament that we mentioned earlier, and we talked about it, which is the transverse acetabular ligament. Transverse because it's transverse in shape, that joins the two ends of lunate surface or the labrum, right? And from it, you will before that, because of the presence of acetabular notch here, so the transverse acetabular ligament converted the acetabular notch into acetabular foramen for blood vessels and nerves. Other ligament, we talked a little bit about it, which is the ligament of the head of femur. This is the head of femur, and this is the ligament of the head of the femur, in which its apex attached to the fovea capitis here on the head of the femur, and its base, which is indeed flat to triangular in shape, right? So its base attached to the transverse ligaments. You see the transverse acetabular ligament. So this is the transverse acetabular ligament, and the ligament of the head of femur attached by its base to it, and also to the margin of acetabulum. So it's intercapsular ligament, as I mentioned, with the transverse acetabular ligament as well. And let me show you how this ligament is, look at the green color. You will see that this ligament is covered by synovial membrane. And if you look also, you can see a branch of a blood vessel, which is the a branch of obturator artery. This is an obturator artery that gives an articular branch to supply the head of femur that passes with it, and both covered by synovial membrane. You see? Now let us shift a little bit deeper, and let's open the capsule and have a look. There you will find a synovial membrane. You know that this is a synovial joint, so we expected that there is a synovial membrane that, as you see here, you see this blue color here. So the synovial membrane in the hip joint, it attached to the margin of articular surface. For example, here, look at the acetabulum here, and I would continue here to show you that the synovial membrane not just attached to the margin of the articular surfaces, but also it lines the capsule itself, and also it reflected on the neck of the femur in order to cover it as well. Look at it here also. It lines the capsule and also reflected on the neck of the femur. What else? Also, the synovial membrane in the hip joint ensheaths or covers the intercapsular ligament that known as the ligament of head of femur. This is the ligament of head of femur, as we mentioned earlier, that attached to the fovea capitis and transverse acetabular ligament. Anyway, the synovial membrane covers that ligament, and also it reflects anteriorly to cover the acetabular, the pad of fat that located in acetabular fossa, as you see here. So this is not everything about synovial membrane, because the synovial membrane can bulge outside. You remember these ligaments we talked about before a couple of slides, the iliofemoral and the pubofemoral ligament. So between them there is an opening for bursa, because the synovial membrane of the hip joint can protrude like a sac outside from there and anteriorly to form something called psoas bursa. Look at it here. This is the psoas or iliopsoas bursa. So this iliopsoas bursa and bursae in general act as a cushion that decreases the friction between, for example, muscle, tendon, and another ligament or structure. And in this case, you see the iliopsoas bursa, which that takes its name from the iliopsoas muscle. So this is the psoas major, and this is the iliacus muscle. So this is the tendon of iliopsoas muscle. However, the iliopsoas muscle anteriorly, it's separated from the hip joint posteriorly by this bursa, iliopsoas bursa. So by this way, it decreases the friction between the moving parts, especially in this case. Okay, now, yes, this is another view for the iliopsoas bursa, which is, as we mentioned, deep to the iliopsoas tendon, and cushion the tendon from the anterior aspect of the hip joint capsule. Okay, that was the synovial membrane. Now let us talk a little bit about the relations of hip joint. Well, simply, if you look anteriorly, you will see that the hip joint covered by mainly three muscles. You know now, because we mentioned the iliopsoas. This is the iliopsoas muscle. This is number one, and you have a pectineus here and the rectus femoris muscle. So these structures located, these muscles located anterior to the joint, iliopsoas, pectineus, and rectus femoris. Inferiorly, there's we have this muscle, which is the obturator externus muscle that will be inserted in the trochanteric fossa here posteriorly. So it passes inferior to the joint. Posteriorly, this is the joint, yes. So we have the sciatic nerve. You have the obturator internus, not externus, obturator internus posteriorly, and the obturator internus muscle, like this muscle, this one, which is located between two sisters, the superior gemellus and inferior gemellus. So we have sciatic nerve, we have obturator internus and superior gemellus, inferior gemellus, and of course the quadratus femoris muscle. Those posterior. Superiorly, you have directly the gluteus minimus. You can say also gluteus medius, but directly you have the gluteus minimus and the piriformis muscle. So that was superiorly. Have a look also to this parasagittal section of the hip joint. You would see here is the hip joint, the acetabulum, and the location of head of the femur that should be here but removed. So look inferiorly, we have the obturator externus, and what we have superiorly directly is the gluteus minimus and piriformis. Posteriorly, you have the obturator internus that's located between the superior gemellus and inferior gemellus, and you have the sciatic nerve as well, and the quadratus femoris. Anteriorly, of course, you have the rectus femoris, and you have iliopsoas. Look at it here, it's separated from the iliopsoas bursa here. Look at the iliopsoas bursa with an extension of the synovial membrane outside. Anyway, so it separates the joint or the capsule from the iliopsoas muscle, which is easy to remember, and you have also the pectineus muscle anteriorly. Okay, now we got an idea about the muscles around the joint that acting on the joint, and let us have a look on the movement of that joint. Well, simply it's a ball and socket joint, which is like a humerus with a little bit of limitation, but so that means we have to expect to find flexion and also posteriorly extension. And also you can of course abduct your leg away, or the hip joint or lower limb away from your body, and that means abduct. And you can also adduct it. So we have flexion, extension, adduction, and abduction. And also you have external rotation, or you can say lateral rotation and medial rotation. And all of these can be conducted as circumduction. Flexion, extension, adduction, and abduction will form circumduction. Now, let us start with the first movement, which is the flexion. Flexion, it's like when you step forward, right? And there are a couple of acting muscle there. You expect, in order to move your lower limb or the hip joint, or to do flexion of the hip joint anteriorly, that means these group of muscles should be contracted, right? So the first one is the iliopsoas. This is number one. So imagine when it's contracted, it will pull your leg up to the front. That means flexion, right? So iliopsoas, and of course the rectus femoris, and you have a muscle here obliquely, the sartorius, and with a little bit of help of adductor muscles. So iliopsoas, rectus femoris, and sartorius will flex your leg. Of course, there is a limitation when you flex your thigh. Of course, there is a limitation up in which the thigh will come against your chest, right? Or abdominal wall, I mean. And of course, if you extend that, when you flex your knee, of course, when you extend your knee, so, and you try to flex your hip joint, the limitation would be the tension of hamstring group muscle from the back. That means, let me show you here. For example, in this case, let me erase that. And here, you are extending now your knee, and you wanna do flexion. So what limits these is the muscle, the hamstring muscle from here. So they will pull your leg and stabilize it, and it prevents the over-flexion of it, right? So this is the hamstring muscle located here and limits the extension, right? So this is the flexion. The extension is pretty simple and easy. If you wanna extend your hip joint to the back, like in this case, right? So this is usually performed or done by gluteus maximus and the hamstring muscles, three muscles from the back. From lateral to medial, they are biceps femoris, semimembranosus, that has or engulfed partially or under, it will locate under the semitendinosus. One muscle like tendon and one muscle like membrane. So we call it semimembranosus and semitendinosus. So these muscles, hamstring muscles, so when they contract, they will pull the thigh posteriorly, and this is called extension, right? So these are mainly extensor muscles. The limitation of the extension, of course, would be from the ligaments that's located most superiorly and anteriorly, the iliofemoral and the pupofemoral ligament. I think if you go back to the slide of ligaments of the hip joint, you will find or you understand what I mean. So that was flexion, extension. Now what about abduction? Abduction, take it away from the center of your body. So how's your femur will be moved like that, away from the center? Yes, this will be under or performed by the gluteus medius and minimus, because they attached here, greater trochanter. So when they contract, they will pull the thigh up. That means, if this is the center of your body, that means you are doing abduction, ABD. Of course, with the help of piriformis as well. and tensor fasciae latae small muscle anteriorly. The tension, the limitation would be mainly the tension of pubofemoral ligament. Let me show you what I mean. It's better to show you here. Yes, this is the pubofemoral ligament, and we mentioned that this ligament limits the abduction of the hip joint, because yes, it catches here and the lower part of intertrochanteric line and to the body of superior ramus of pubis. So by this fiber, it limits the abduction. So adduction, move your thigh close to the midline. Usually adduction made by adductor muscles. Here, adductor longus, adductor magnus, adductor brevis, which is not shown here, and you can also perform by pectineus muscle and gracilis here medially. This muscle, with the help, of course, with obturator externus, because it's located here and back to the trochanteric fossa. So once contracted, it helps in adduction of the hip joint. The limitation of adduction will be by the ligament of the head of femur, because you know this is the head, for example, head of the femur with the ligaments. So when you abduct it, there's a tension will be prevented here. This is number one. And when your thigh comes against the other thigh, it's also considered a limitation to not adduct it more and more. So that was flexion, extension, abduction, and adduction. Still, we have lateral and medial rotation, where they are easy. So in lateral rotation, that means you have to move your thigh in that direction out. That means the anterior surface of your thigh should be moved laterally. That means lateral rotation. The anterior, let me show you here. You can, this is the lateral rotation or external rotation. The anterior surface of the thigh should be moved laterally, and vice versa with internal rotation. So in lateral rotation, so you see the gluteus maximus like kind of from here. So once contracted, it pulls the anterior surface of the thigh laterally. Also piriformis helps, obturator internus, superior and inferior gemini. All of these, quadratus femoris, all of these groups of muscles, when they contract, imagine they will pull the thigh laterally. And the limitation of lateral rotation, limited by iliofemoral and pubofemoral. But the limitation of medial rotation limited by ischiofemoral ligament, because located here posteriorly, right? So when you do medial rotation, the anterior surface of the thigh moved medially. This ligament will limit the over medial rotation. So the medial rotation usually performed as you see here by the gluteus medius and minimus, because they attach the greater trochanter here, so closer to act as a medial rotator, in addition, of course, to the abduction, because it has anterior fiber here. I want to talk about the anterior fiber that helps in the medial rotation, in addition to the tensor fasciae latae as well. So the blood supply for hip joint is important, and you have to know that the hip joint in general supplied by an anastomosis known as trochanteric anastomosis. You remember the greater trochanter and lesser trochanter, so this anastomosis is known as trochanteric anastomosis, in which there are 4 blood vessels help in forming that anastomosis around the head and neck. So mainly look at here. This is the deep artery of the thigh. This is the femoral artery. This is the femoral artery, and this is the deep artery of the thigh. From there is a lateral circumflex femoral artery, and there is a medial circumflex femoral artery. So you have lateral and medial circumflex femoral artery with the help of superior gluteal artery and inferior gluteal artery, which is the branch of internal iliac artery, as you see. Plus, the obturator artery here also gives articular branch that passes through the acetabular foramen, and it's known as articular branch. This articular branch, if you remember here, let me show you where is that. Yes, here is the artery of ligament of head, right, which is the articular branch of obturator artery. This is the obturator artery here that gives obturator arteries here that gives articular branch that passes with the ligament of head of femur and covers, of course, by synovial membrane. So this is mainly the blood supply of the hip joint. And somebody can say, okay, what about the nerve supply? Simply according to Hilton's law, if you want to know what the nerve or nerves that innervate that joint, just you have to know what muscles acting on that joint and what the nerves innervate those muscles. For example, in hip joint, you have to remember the muscles acting around it, and in this case you have the femoral nerve, mainly also obturator nerve, plus superior gluteal nerve and nerve to quadratus femoris muscle. So these muscles innervate the hip joint, but also mainly the femoral and the obturator also gives innervation to the knee joint inferiorly. So pain arising in the hip joint can be referred and felt in the knee joint. This is a referred pain. So lastly, in this part, before going, I think, to clinical part, we have to know that because of the shape of the head of the femur, that's more than a hemisphere, I think 2/3 of the sphere, I think, and because of the acetabulum labrum, that means the shape of the head and acetabulum that's deeper than the humerus, if you compare it to the humerus, and because of the presence of extra capsular ligaments, iliofemoral, pubofemoral, ischiofemoral, posteriorly. So, and the muscles that surrounding the hip joint, all of these factors participate and help and support the strength and stability of the hip joint. Just show you a couple of things related to clinical anatomy, in which I mentioned earlier that the femoral nerve and obturator nerve as well, they participate and innervate the hip joint, and also they innervate the knee joint. So pain, for example, originating in the hip joint can be referred at the first. You will feel the pain in the front and medial side of your thigh. This is because the femoral nerve innervating there. And Also, the hip joint, there's pain for a reason or another in the hip joint. The pain can be felt in the knee joint because also of the presence of the obturator nerve that supply both of the joints. Now, there is sometime, congenital dislocation for the hip joint, 1 to 2 babies in every 1,000, in which, for example, this here, you will see the dislocation of the hip joint, in which the head of the femur um, uh, dislocated superiorly above the acetabulum, and you notice that the dislocated limb is like shorter than the normal one. It's mostly it may occur bilaterally in both limb, but also it's in female more than in male. So there is two maneuvers or tests can be done to test any, say for example, any deformity or a weakness in the hip joint, and the first test is known as Parlo's test or dislocation test, in which the knees flexed and the thighs are adducted close to each other, as you see. Then with a gentle pressure against the thigh in order to feel if there is any dislocation will occur posteriorly, and in this way you are examining any hip instability. If there is instability in the joint will be shown, and the joint will be dislocated posteriorly. Now, in order to confirm that the hip joint dislocated, you have to do another test, which is the reduction test. It's opposite to the Parlo's test. Now it's called ortholanus test or reduction test. Ortholanus test is opposite to the Parlo's test, and you're trying now to relocate the dislocated hip joint, in which, as you see here, grasping the at the first you flex the knee and the hip joint, and you are abducting the thighs away from each other, and by the middle finger you are catching or palpating the greater trochanter in order to push the femur up from the dislocated location and bring it to the acetabulum. Once you do so, you will feel, if it was dislocated, then you will feel like a dull sound or a clunk sound, something like dull sound, which indicates the returning of the head of femur to the its normal location, the acetabulum. So posterior dislocation is common, especially if you adduct if your thighs are adducted. That means your legs close to each other, and the hip is flexed. In this case, the joint is more. You just imagine, you understand what does it mean when they are flexed and adducted. They're close to each other and flexed. That means the joint is more vulnerable for dislocation posteriorly, right? So in this case, when there is a vehicle accident, when you have a push on against your knee, so the hip joint can be dislocated posteriorly, in which in this case, for example, you see the hip of this is the normal look at the head of the femur that's located inside the acetabulum, and here you see that the head of femur is dislocated posteriorly into the gluteal region. This is the head of the femur, and this is the gluteal region. So this is the acetabulum, right? So it should be here, but it's located posteriorly, and mostly the sciatic nerve is the most nerve prone to be injured, this is important. Look at this patient who has a posterior dislocation mainly of the hip joint, in which look at the lower limb, which is flexed and adducted and medially rotated. The anterior of the thigh is rotated medially because it's dislocated and of course shorter than the other limb. Thank you, and hope you find value in it. Thanks.